name is Laura Bonilla, and I am the Maryland Rhoda Project Coordinator. We are pleased to welcome you to this webinar on comprehensive community-based harm reduction in Maryland. Maryland Rhoda is part of an initiative by the Substance Abuse and Mental Health Services Administration established by the University of Maryland in partnership with local and state organizations. Our project aims to strengthen the capacity of rural communities in Maryland by helping our communities identify, understand, and respond to the opioid misuse epidemic. Our multi-pronged approach includes delivering evidence-based training, providing current information and education, and strengthening youth against opioid misuse. For example, we encourage you to join our Rhoda network to learn about best practices, ask questions of peers and experts, and share your local experiences. More information about Maryland Rhoda and a link for joining our network are available at www.marylandrhoda.org. Today, we are excited to be joined by our presenters, Erin Russell, Chief of the Center for Harm Reduction Services of the Maryland Department of Health, Prevention and Health Promotion Administration, and Vicki Sterling, Director of Behavioral Health Services of the Washington County Health Department. This webinar will be approximately 60 minutes long, and we encourage you to submit questions during and after the presentations. Please do not raise your hand. Instead, we ask that you please post your questions in the Q&A box. We will hold a Q&A session after the presentation. We will do our best to get to all your questions, and we will try to address any remaining questions after the webinar. A recording of this webinar will be made available on our website, www.marylandrhoda.org. You can find the webinar page under the Services tab. Thank you, and we hope you enjoy this webinar. Erin, I'll hand it over to you.
So good morning or good afternoon, it's noon. Good afternoon, everyone. Again, my name is Erin Russell. I'm Chief of the Center for Harm Reduction Services and very excited to talk to you this morning about the work that we do, the goals we've set for the next year, and how we are putting harm reduction into practice in Maryland and in the ways that we operate our programs. I want to first thank you for hosting me and Vicki Sterling for this presentation. I'm very excited to turn it over to her after I talk to you for about 15 minutes, and then she'll go more into detail about how things are working in Washington County, where we have one of our long-standing now harm reduction programs. They've been doing syringe services for over, it's been a year, I believe, but she'll give you the history of that. But they've been integrating syringe services into so many other programs in the county that are helping to support people along the continuum of care. So I'll talk a high level, just kind of orient you to the center, and then turn it over to Vicki to talk more about what's going on the ground in Washington County. So as I get into the overview of the center, my goals are to not just give you a long list of the programs that we manage or that we fund, but to show how they are integrated and have built on each other in order to create kind of the incredible movement that we have in Maryland towards harm reduction. There's a lot of really incredible people doing this work on the ground and doing mobilizing and advocacy in their communities and statewide that have really led to our ability to have such comprehensive statewide support for this work. So as a center, our vision and our goal is to not only reduce morbidity and mortality among people who use drugs, but have a Maryland in which healthcare and social service systems meet the needs of people who use drugs in a comprehensive and community-based manner. We really believe in locally driven interventions. I think our purpose is to get funding and resources to communities on the ground because they know the best way in which to put those resources to work. People who use drugs should have equitable access to high quality care. And we take that very seriously, that our syringe service programs, all the programs that we fund, the care should be the high quality that you would expect walking into any clinic or any healthcare service. And we're working on ways this year. One of our goals that I'll talk about later is to measure that, throughout the year. And finally, services provided to people who use drugs are free from stigma and discrimination. So we do a lot of work to also build capacity of organizations so that they have the cultural competence to serve people who use drugs. And also community education initiatives that help create that community awareness and that supportive environment in which harm reduction programs can succeed. So I know this is kind of a boring org chart. It just shows where we're situated in the Maryland Department of Health. And we are under Public Health Services, which is the far left part of the org chart. So Public Health Services is alongside behavioral health. So we work in close partnership with our colleagues in behavioral health, and you'll see a lot of our goals overlap with them, and I'll kind of talk a little bit about how that partnership works. But we're housed in public health, and that has been had incredible benefits over the last year because we are located alongside the Center for Hepatitis Prevention, Sexually Transmitted Infections Prevention, the Maryland's AIDS Drug Assistance Program, and then HIV Prevention and Health Services. So when things like the hepatitis B outbreak, which happened in Cecil County last year, the same strain of hepatitis B that was seen at that time in Philadelphia, we were able to be kind of in the loop, we're already working closely with our infectious disease colleagues. And so we were subject matter experts to ensure that the response involved people who use drugs and the programs that are already on the ground serving them. And Voices of Hope and Cecil County Health Department responded very quickly, and they ended up integrating hepatitis vaccination into their outreach work, which is just truly incredible. That process just showed how important it is that we have a close tie and strong understanding of infectious disease and how to respond. So it's also, I think, culturally, it's been interesting to be housed in infectious disease. There's a lot of people who worked on HIV for many years, and HIV care came about because of so much work of activists. It was very, a lot of not being heard in the early days, and HIV not even being acknowledged by our federal government for many years. And then it took a lot of mobilization and activism to get the infrastructure that now exists to treat HIV and AIDS. So harm reduction is parallel in some ways. People who use drugs are neglected on so many levels, and there's a lot of activism, a lot of fighting for those rights to be acknowledged and honored. And so we are kind of part of the institutionalization of that fight, and kind of making sustainable these programs that are now within the health department. So very similar to how Ryan White services are now run by the health department. So we're learning a lot from those who are working in that area as we build all these programs. So in a quick snapshot, this is the work that we oversee. So we're split into two arms. One is services, and we also do a lot of policy work on that side that supports and facilitates these services. Then the other side is capacity building and training. So on the services side, it falls into kind of three major programs: naloxone, our harm reduction grant program, and syringe services. So the biggest thing to point out is that for both naloxone and syringe services, there is a process in place to approve programs and give them that legal authority to distribute naloxone through a standing order and to add exemptions from the paraphernalia statute to provide injection equipment for the prevention of infectious disease. So we are responsible for that process. And we have staff who receive those applications. We have rubrics for evaluating them, and then a process for sharing it with our partners and internally in order to get approval. We also monitor programs moving forward. We collected data on naloxone distribution. We also have regular quarterly reporting requirements for syringe service programs to understand who they're reaching, what kind of supplies are getting out, and we use that to constantly monitor and evaluate how our programs are doing, who we're reaching, where we need to expand. Finally, with harm reduction grants, the competitive grant process for both local health departments and a separate process for community-based nonprofit organizations. I'm so thrilled and excited about this area of our work. Again, it's where we are getting resources to communities and giving them the opportunity to assess community needs, say what they need funding for, and work out a grant agreement with them to meet those needs. So over the past year, we funded all the drop-in spaces in Baltimore City that serve people who use drugs, a lot of peer outreach, a lot of outreach of organizations, as well as case management. I'll add some other fun stuff. I know we're funding art therapy and yoga in some of those drop-in spaces. And as well as some organizations who just want to better serve people who use drugs. So they're hiring consultants to take a look at their policies, they're training staff in that, and we're excited for that area of the grant program to grow as well. Finally, one of the other major areas of funding is partnering with Ryan White service programs and buprenorphine providers, and incorporating and kind of co-locating those services. So we fund 2 buprenorphine providers that have incorporated HIV testing into their services, and so we fund that now with Ryan White. And we're looking to expand that work as well. So again, it speaks to our goal of making programs comprehensive and reflective of the needs of the community. So on the capacity building and training side, our biggest program is regrounding our response. And there's probably many people on this call who are familiar with that program and master presenters themselves. Last year we trained over about exactly 125 people to become master presenters. They are competent in 5 areas, 5 key concepts that address the stigma of substance use. It's based on the understanding that if you can understand stages of change, adverse childhood experiences, the social determinants of health, medication-assisted treatment, and drug user health, then that will help you. Will help someone to understand addiction, what drives addiction, kind of the social environment, and like the risk environment that creates the crisis that we have today. So it's more of a community education project, and what's exciting about it is all those master presenters are committed to doing trainings in their community. So it's kind of a sustainable long-term model where we have people committed to doing that training over time. And we're going to expand that in the next year as well, identifying new trainings and making them more targeted and specific. We also partner with Behavioral Health Systems Baltimore to have a Maryland Harm Reduction Training Institute. This is a way of providing Harm Reduction 101, Drug User Health 101. They do a lot of stigma trainings, but they are also a partner in providing the core training to syringe service programs. And this is a comprehensive training to give someone the skills they need to operate and work in a syringe service program. It also supports the leadership development of people who use drugs. We work very hard to ensure that all of our programs are incorporating the voices of people who use drugs. It's actually a condition of award for our grant program that you need to demonstrate how you are seeking feedback or involving the community on your leadership team or as an advisory panel, things like that. And so that also involves working with the community to prepare them and support them in that, in sharing their voice and opinions about programs. Okay, two more things with training. We are the lead trainers for the state. The Governor's Office of Crime Prevention, Youth and Victim Services funds law enforcement assisted diversion, and we have a partnership with them that positions us, the Center for Harm Reduction Services, as the trainers for those sites. So we're developing training for both law enforcement and the providers that they partner with that do case management for people who are diverted. And so we're excited about that partnership. It's a way for law enforcement to have a tool that allows them to not just arrest and send people to jail as their only option, but to identify people who may benefit from intensive case management. And then instead of even going to booking for an arrest, you are connected with a case manager who provides linkage to care regardless of your drug use status. They've seen great success with this program in other states. So it's pretty incredible that is building up so rapidly in Maryland. And I'll share a map in a moment of where those lead sites are going to be. Finally, we support coalition building, and this is really just supporting the work of the Maryland Harm Reduction Action Network that provides training to people on advocacy and really mobilizes people and gets them to Annapolis when there is a relevant harm reduction bill during our legislative session. And there's also a listserv that many of you, if you're not on that listserv, I highly recommend it. But it's a listserv that's currently facilitated by the Baltimore Harm Reduction Coalition. And it's an information sharing network that spans things from here's a new grant opportunity, hey, I'm looking to partner with somebody in Worcester County, or I'm looking for treatment for someone in Calvert County. Can anyone help me out? So there's a lot of good interaction on that site of people working in this field. All right, the next two slides are maps of where our programs are located, and really hoping to see syringe service programs align with law enforcement assisted diversion programs. Now we got a little ways to go, but you can see that many of those counties do overlap. And I know Vicki will address how this works in Washington County, which I think is going to be really, really interesting. And I can just say anecdotally, it works so well when they're both located in the same county because law enforcement education is so important when you have a syringe service program, making sure that the law enforcement just understand the program, understand where this paraphernalia is coming from, and understand that the changes to the law that mean that someone cannot be arrested, charged, or prosecuted for that paraphernalia. And in Washington County, I've just heard of law enforcement really demonstrating that they understand the public health purpose, and that has made interaction between the syringe service program participants and law enforcement better in many cases. So that's just an incredibly important component because negative interactions with law enforcement are obviously can be harmful to someone emotionally, but it also then erodes the trust that people have in their right to access a syringe service program and the trust that they have in their associated providers to that program. So again, having all this harm reduction work kind of coalesce in one county is, I think, going to be really powerful over the coming years. We have a total of 12 approved programs. The latest programs being in Howard, Anne Arundel, and Wacomico. 2 programs are nonprofit organizations in Baltimore City. And again, we're hoping that will grow. However, 2 health departments do work closely. I already mentioned Voices of Hope in Cecil County, and in Prince George's County, they also partner with a nonprofit to deliver services. These are the lead programs that will be receiving funding from the Governor's Office of Crime Prevention, Youth and Victim Services. So a lot of rural counties, which is really exciting. Great. So I will just got 2 more slides before I turn it over to Vicki. I just want to highlight here, I know this is a very formal text-heavy slide, but I didn't want to mince words on what our goals are for this year, because I'm really, really proud of them and proud of my team for putting this together. The strategic goals really, I think, speak to, again, our mission to co-locate services, integrate care, make programs comprehensive as much as possible. So we really hope we plan to see more integration of hepatitis C testing and hepatitis vaccinations in like physically located with syringe service programs so people can be tested on site. We anticipate co-locating buprenorphine with syringe services in a mobile setting. And again, ensure that all programs are offering insurance navigation to their participants. That'll be a new thing this year, but we think that by ensuring that people have that opportunity to connect to coverage, then they'll be able to access all the referrals that they're getting. And harm reduction programs, the outreach that people are doing, and in certain service programs, referrals are so strong and so important. All these programs have really incredible referral networks, especially when they are run by people who identify as peers who have lived experience. They've navigated the system themselves, and they know the providers that are really good. So when all the programs I think that are peer run and offering these referrals are just so strong and consistent in that, and we see really good follow through on care when that is the case. So adding in that insurance coverage will help to even further strengthen these referrals that people are receiving when they go to a program. Right, so these are just a few highlights. It's Vicki's team. There's my little transition note. I've got logos from organizations. I just wanted to throw some things up here to show how diverse and multifaceted the movement is in Maryland. I think it's truly incredible. The Go Slow campaign is another one you might have heard of. Be More Power was one of our first naloxone street-based distribution program, and they're still doing outreach in Baltimore City through COVID, through it all. The bottom right, Baltimore made it on the cover of Time magazine for a second time. Same photographer, Devin Allen, documented a protest for Black Trans Lives Matter, and that was run by one of our grantees, Baltimore Safe Haven. And they run a drop-in center in Baltimore City and provide supportive housing to people who are trans. And BHLI is another Behavioral Health Leadership Institute, another grantee. They're doing mobile services, and they park their van outside of the jail as a way of reaching people who are just recently leaving jail and being in a location where people can easily know where they are. So again, proud of that work. And they're one of our grantees that's incorporating HIV testing and linkage to care into buprenorphine services. So I will turn it over to Vicki. Thank you, and I look forward to your questions and learning more from all of you as we move forward. Here's my email if you need it for follow-up.
Thanks so much. I'm excited to be here. Erin, I was really happy that you shared a picture of my team, because that really is the reason we're successful. I think I have a really good team. From the beginning to even today. But I just want to talk about, obviously I'm the Director of Behavioral Health at the Washington County Health Department, and under me is Harm Reduction Services. And today I just want to talk about sort of our history, how we were implemented, some of the ups and downs. I call them mountains and highlights, or mountains and sunshine. And sort of how we've taken different programs throughout the health department and integrated and kind of work together to make everything more smooth and just kind of improve services. So the vision of behavioral health services is to have a community where all individuals have their behavioral health needs met. And our mission is to provide prevention, intervention, treatment, and recovery services to individuals in Washington County that are affected by behavioral health issues, while working towards an integrated system of care that can be accessed to everyone to meet their individual needs. And I just think that's so important because our programs are really interrelated, and our harm reduction program follows this overarching theme as a guide for the vision and mission. But some of you may not be totally familiar with Washington County, but I just wanted to give sort of like a little snippet of what we look like. So we are in rural Western Maryland. We border Virginia, West Virginia, and Pennsylvania, which is kind of unique and also a problem because we are a tri-state area where two major interstates intersect of 81 and 70. So we are identified through HIDA as a high-intensity drug trafficking area. Our population is about 150,000, and our median income is 59. And when you look at our data for Medicaid, 30% of our population is eligible, and we are ranked 8th in the state for population and poverty. Our substance use data, as you can see, of course, we still are continuing to see a slight increase in overdoses. Our largest increase was in 2017 to 2018. We did go down a little bit in 19. I'd like to think that's because we were more visible, and that actually between 18 and 19 is when we implemented fully our harm reduction services. As you can see, we are up a little bit this year, mainly due to COVID and a decrease in service, but we were able to remain open during COVID, and I'll talk a little bit about that when I talk about some of our highlights. The biggest increase in Medicaid costs when we look at sort of our treatment cost from 2016 to 2017, it was 54%. And last year we spent $17 million in SUD treatment, which is about $1 million more than we did in 2018. And when we look at these admissions to treatment, 34% of the admissions reported opioids as a primary drug, and then alcohol as a secondary. We've always recognized in our county that alcohol is also an issue. So in 2016, it was late in 2016, our health officer and deputy health officer decided to move forward an implementation of our harm reduction services. And this really was based on the CDC study related to the Scott County, Indiana outbreak, where in 2015, they looked at what counties or jurisdictions were most vulnerable to an outbreak. And one of those counties was Berkeley County, and we border Berkeley County. And it just so happens that our deputy health officer, Dr. Gaviria, was coming from the health department in Berkeley County and really recognized the risk. So late 2016, we started the application process. I believe we were the first in the county to move forward. We worked with Andrew Bell, and I can say that it was a very long and thorough process, but when we look back, David and I always laugh, that's my program, David Washington is our program director. We always laugh and say it really prepared us for what we were gonna come up against moving forward. And we'll talk about that when I talk about sort of the mountains and things that we've been faced with. But it prepared us well, and it really laid a really good foundation for starting and implementing services. So we really took that year to work on building capacity and educating our community on the principles of harm reduction, and even ourselves learning what harm reduction really was about. And through that, the staff started to do outreach to individuals who are people who use drugs, learn the landscape. And I think one of the most important things that I will always say to someone implementing a program is to listen. Just listen closely to the people that you're trying to work with, to your providers, and to your community. And you will learn a lot. So it just gave us a really good foundation to build those relationships and educate people on harm reduction. And really our focus at that time wasn't syringe services. I mean, that was part of it, but really broadening the educational piece to include all aspects of harm reduction services. So it was more accepted throughout the community. We did community outreach where we would go in the evening, maybe late at night, say 6 to 10, and just set up a table in high risk areas and provide snacks, safe sex kits, naloxone, hygiene items, and just build that, just build relationships with people in the community. We did community presentations from anywhere you can imagine. David was really good about it. We went to like jails. We targeted churches, the Hagerstown area religious coalition, housing, Department of Social Services. We also did roll call, and roll call was a very important piece of the education and capacity and relationship building, where we, once we were actually in full implementation, we did a lot of education around what the cards look like, what to expect, sort of the legislation, just so the officers knew who to call if they thought they needed support or they had someone they wanted to refer to us and things like that. And that has been a huge benefit moving forward. We still go to roll call regularly. I think it's every quarter, and we rotate just to touch base, see what they need, how we can support them if they have information for us or things that they need from us. Community presentations, we did a lot of that, and then partnerships with providers. So we also partnered with providers in our substance use disorder network, the OTPs. We still go and give presentations to providers and their clients. We actually are scheduled to go out and set up a table, I think next week at one of our OTPs. So that's been a really important part, because we do get referrals from the providers. And then we started a harm reduction advisory council, because we know that we didn't want to make decisions without people at the table that it affected and giving them a voice. That's been challenging sometimes. Sometimes we have trouble getting people who are actively using it to the table. But we have had people in recovery, early recovery come, and we do get input from the people that we serve. In our first year, we did a survey that was very helpful, that kind of helped us guide us through the second year of how we could do better. We also began a cultural humility group, which was for our staff and community service providers, just in hopes that we would increase the quality of services and delivery. We also do the backpack model and location. So when we first began, location was always an issue. Like I said, we had gone to the area religious coalition or council on, and we presented to them, and we were really, the churches were really supportive. And in the beginning, we had 2 churches reach out to us for to be a location. One was in a rural area of Smithsburg, and that fell through. I think the sheriff was not happy with that, so we decided not to go there. And then we had another church, and there were some issues because there was a daycare in there during the day, and they preferred that we not be there while the daycare was there. But so we ended up starting at a church downtown 1 day a week, and that kind of we still go there, but then they sort of felt like they did not want anyone, didn't want to serve, because we were serving, and we were providing services during a lunch where they feed the community. And then the church decided that they didn't want individuals. They sort of had a no substance use policy, or people couldn't have drugs on them while they were there, and where they were kind of concerned. Where we still have a good relationship with them, and we do naloxone distribution there once a month. But we really ultimately ended up coming to the health department at our satellite office where behavioral health is, and opening up the clinic every day from 8:30 to 4. So we have, the clinic is open Monday through Friday, 8:30 to 4. That's kind of where we ended up landing at this point, and branching out, hopefully branching out in the next year with a mobile unit to our outlying areas, because we're kind of a large county. So that was one thing that we learned early on too, is that the best laid plans, sometimes you just have to pivot and change. So location was one thing that we kind of went back and forth with, but we ended up at the health department, but we also use the backpack model where and when the weather's permitting and things are nice out, we'll go out one day a week and just walk around and talk to people. And some people, they get enrolled, or they'll see people that are already enrolled and they're able to service them in the community. We also do community delivery. So if someone calls in, transportation is a huge thing here. We don't have very good public transportation, and it makes it difficult to get actual to the health department. So we will do community delivery if we need to. Naloxone education and distribution, we do a lot of that. We provide those at community events such as Pride. We do it out in the public wherever. If we do an outreach, like this morning, they did outreach downtown in our city market lot, and they were able to provide education Narcan to 25 people. We also do a lot of infectious disease education and testing. Prior to COVID, we were having, and we still are having, a syphilis outbreak. So we had been doing outreach last summer, doing testing on Friday evenings from 7 to 10 at night. And we would, again, incorporate that outreach into the testing, where we would just walk through town and let people know where we were and what we were offering. And they did have an incentive at that point in time. We also go to our LGBTQ local bar. They love to have us up there. We set up a table with information on sexual health, and then we have a van that we do hep testing, HIV, and syphilis testing there, and we do that about once a month. And then this year, we started a new program called Harm Reduction Works Group, which is a harm reduction support group. It's evidence-based and scripted. It's gotten a really good turnout and positive review. I know pre-COVID, the group members were kind of upset that we put it on hold. So we're gonna restart that, and hopefully maybe even sort of incorporate that into our advisory council, because it does have a really good attendance. We also do community cleanup, which has been very positive. It builds relationships in the community. If someone calls and they find syringes, we'll go out there and clean them up. Or sometimes officers will call us and say that they've found a spot that needs to be cleaned up. And then we also just do community cleanup, where we go to high-risk areas or that we've had reports from our overdoses, and just walk around, but also making that connection with community members and telling them and talking to them about some of the services that we have. We also do outreach to high overdose areas, and we have been working, since we're short-staffed, some of the harm reduction staff have been responding to the overdose reports and going out and talking to people that have experienced multiple overdoses. So we have a lot going on, and we continue to grow and develop the program, but those are sort of the things that have guided us through to where we are. We did start, we were in full implementation. We're able to open the clinic in 2018. So we've been open about 2 years, and we just continue to grow. This is, and I always like to show this, I know Erin showed a little bit of my staff and then the emblem, but we have the nickname Hub City Strong. That's our Facebook page, and it's on a lot of our t-shirts and things. We've also developed this tree, which we have as a poster in the clinic room. So if anyone comes in, a lot of times they told us that they don't feel well sometimes when they come in, and they just don't want to talk. So we will say to them, is there anything on the tree that we can help you with today? So it may be overdose prevention. We can talk to them about that and get them fentanyl test strips or Narcan. That's also on there. If they need testing, we're able to do that. We always have enough staff actually here that can test if they need safer injection equipment. So it's just been really helpful. And it's my favorite little logo that we have. So it's just really helpful. Not everything has always been smooth, and there's always been some mountains that we have to climb. And I like to say mountains because we are making headway, and sometimes we get over one and then another one crops up. But some of the things that we've really found challenging, one is continued trust. People don't believe that this is happening and that we are the health department. Gaining their trust, understanding that we are here to help and that isn't judgmental, and that, this is a real thing. It is working. As you'll see, our numbers are pretty high right now. And I know, having worked the clinic during COVID, the community actually is starting to open up, especially the community of individuals who use drugs are really starting to gain trust in the program and feel safe coming here. Staffing is always an issue. Right now, we're actually down 2 peers. So it's just difficult. It's a tough job, but we also have individuals who may get certified and then leave for something else or another opportunity. And plus, we really don't have a large pool of actual certified peers. But we do have really good peers that work for us. That have kind of started in different areas in the health department and moved over. But we are hiring 2 right now. Stigma, of course, is always going to be an issue just in general. We were coming into the office one day during COVID and somebody looked over and said, "Oh, that's where all the drug addicts go to get their drug material," or something like that. So there's always the language in the community that we just work really hard to combat and educate and continue to work on that. But that's always going to be sort of one of the mountains that we'll climb and make headway of. The geographic makeup of our county is large. It's very large. Hancock is the most western part of the county, and that's about 30 minutes away. And there's not a lot of resources up there. So when we look at sort of community outreach, it's very difficult to hit all of the spots with our outlying, like we have Hancock, Smithsburg, Sharpsburg. We go deep almost to Frederick County. So that's just been a challenge. We are working on getting a mobile unit so that we are a little bit more mobile. And then reaching specific populations. Specifically, we have had difficulty reaching the sex worker population. That's something that we really have worked on and we're going to continue to focus on this year because we know that that's a population that we just have not been able to reach and connect with. And then the last one is political opposition. Most of our politicians back the program, but it definitely is a hot topic. And it's one that most people don't want to publicly support. Recently, one of our delegations submitted legislation to have Washington County cut out of the legislation or carved out so that we could not provide cleaner injection equipment. And this was done in sort of a stigmatizing way. And it was done in a way through the county that kind of caused shock. So there was a little bit more support than we thought that there was going to be. We actually had a legislative aide come into the clinic as a client, and our equipment was referred to as drug starter kits, which we kind of missed the whole point of what we do. But we were able to have a voice and do a presentation and explain the process and the safer injection equipment and the resources that we do have and what we give people when they walk in. And that was a big mountain to climb, but we had a lot of good support. Our law enforcement supports us tremendously. And I'll go over that in highlights, but we have good support from the state and from our law enforcement. So highlights, currently we have 535 participants. We have done 266 referrals to treatment, which I think is just an amazing number in that short amount of time. Because if you think even of a private practice that provides SUD treatment, they probably don't make that many referrals to another level of care. So I'm really proud when I say that, because people, you know, my peers are always trying to work with people that want to get into treatment. We've distributed 4,500 plus naloxone. We've done education and distribution. We've distributed 145,927 syringes, and they've completed 184 outreach and community education events. Like I said, law enforcement support is just amazing. Our sheriff actually sat on the state advisory committee for syringe service implementation, and our chief of police is extremely supportive, and our fire chief is really supportive. And actually, the sheriff's department testified in front of the county commissioners for syringe services and against the carve out of the legislation. And we were able to, another highlight is we were able to maintain services during COVID. We felt that that was mission critical. So we were open every day from 10 to 2. Individuals could come to the door and we would take orders and bring them out. When we were really low staff, we just did pre-packaged shorts or longs. So they'd have a pack for a time being. So we were able to do that, and it was really successful. People came. At first, they didn't know what was going on, but then after a while, word spread and we were really busy. Now, we're still not open to the public, but we're still providing services. We can meet them somewhere in the community, or they can come to the door, or they can call in their order of services that they need. And we're still able to get people into treatment. So program integration, this is one thing that, you know, I think is so helpful within our division. We have harm reduction services, leads as a lead, as Erin had talked about. We implemented law enforcement assisted diversion in August of 2018. We have targeted case management, and we also have partnered with our crisis intervention team. So the sheriff's department has really taken the lead on this and has trained their officers, and I mean, they have done an amazing job. And it's really exciting to see them come to the table and say the things that they do. You know, we've had them get a hotel for a couple once they were pulled over, so that they could meet with their lead participant or their lead case manager the next day. They tried to not get their car towed so that they would have transportation. Just amazing teamwork and the way that this has come together. And we have seen successes even in that short amount of time. We currently have about 26 people in services. And one of the things that always sticks in my mind is we were in a meeting and we were talking about an individual, and they were like, I don't think like we're making any difference. And the sheriff's department said, this is a person who had 45 calls to 911 in a 30-day period. And here in the last 4 months, they've made 2 calls. So those are the things, and that's what makes LEAD so successful, and the partnerships. So we've had a really good partnership with that and really good outcomes so far. The Potomac Case Management is our case management entity, and they are very supportive of the harm reduction model and understand the public health necessity. So that's good, and so do the officers. And it's good to hear participants say, you know, they took my drugs, but they didn't take my equipment. So we are making headway, and it just is good to see that this is coming. This has been had positive effects on our community. We also have the overdose fatality review team, which we are working on reviewing non-fatals, and we can make referrals to harm reduction and outreach, and that kind of combines in with our crisis services because our peers through harm reduction also go out and do outreach to individuals who've experienced an overdose when we get the reports. The other program that we just implemented about a year ago is academic detailing, and that's really prescriber outreach. But through some of the information that we gain at harm reduction, we're able to inform and educate prescribers in the community about some of the things we're seeing. For instance, we did messaging around disposal of needles, because we were hearing that, you know, when they were getting syringes from doctors, they weren't getting on how to dispose of them. So we kind of talked about that. We also, of course, do a lot of information on buprenorphine and increasing capacity. We're excited to say that July 10th, we're doing a training of all of our residents through Max in our residency program at Meredith. So there are about 12 residents that will be trained for bup waiver in the primary care residency program. And then our prevention also works with harm reduction on naloxone distribution and education, and fentanyl test strips. Our harm reduction staff is David Washington. He's our program coordinator. And then we have Alicia Laban and William Flood are our peer support specialists. William is actually full-time lead, and Alicia is partial lead, partial harm reduction. They're both kind of filling in because we have two positions that are not filled. So on a full scale, we would have 200% harm reduction peer workers, and then we would have two peer support specialists that are 50% harm reduction and 50% lead. And that is my contact information. And I thank you guys for your time.
We will now begin the Q&A portion of this webinar. We encourage you to submit your questions to the Q&A box. And so the first question is for you, Vicki, and I think you touched a little bit on this, but someone asked, what have you all done during COVID-19?
So COVID-19, I did touch a little bit on it. We obviously were open from 10 to 2, Monday through Friday. We do have a couple people. We do have one person in particular that is sort of our rock star in the community of individuals who use drugs. And we really relied on her to get the word out and make sure that people knew we were open. And I think another thing was that when they came to the door, we really talked to people. Like, we went out there, masks on, social distancing, but really had those conversations. Like, is everything okay? What do you need? Is there anything we can do? Can you let people know that we're here? You know, and safer kids. I mean, like, we were packing these with everything that we could think of that would be helpful, like sharps containers, extra Narcans. If they said, oh, I only want 2 kits, I'm like, why don't you take 4, just because you don't know when you're going to get back, and just having those conversations. So I think that's really what helped. I will say I was shocked. Our first week, we were like, okay, we got to do this. People would call in. They were really annoyed because, one, and I didn't think about it. This is when I say pivot and listen. They had no idea what was going on. They're like, why are you asking me these questions? What do you mean? Do you have a fever? And it just, you know, they were so disconnected that they really had no idea. So then really kind of turning around and saying, hey, this is what's going on. We need to ask you these questions. You know, we're concerned about your health. What can we do to help you? So that was really the basis.
Okay. The next question, Vicki, what were the strategies used to get the Sheriff's Department with such a significant investment?
You have to identify, and I think everybody would, Erin will probably agree with this, and GoCap, you have to identify your superstar on the force. Like, you have to identify the ones that have already shown an investment in sort of harm reduction principles and individuals, especially with the mental health. I think another thing is partnering with the CIT team because they already have that connection with law enforcement, and that's what we did. And they've already, and it kind of, I guess, kind of all fell at the right time. We got a new CIT leader who is amazing and was already starting to do those trainings. So she was able to kind of pick out those people that we knew would be kind of the what we call super users.
Can you describe what you have done in terms of communication to people who use drugs as well as others? Have you done any communication campaigns?
So I can start. Harm reduction is, built into the community if it's done right, and really honors, I think, the natural communication among people who use drugs and networks of people who use drugs. We know that a lot of people use drugs in communities and they talk. And I've heard that one of the best things that you can do to have an effective program is just do the program really, really well. It will speak for itself. You won't need to promote it. Because word spreads, and Vicki touched upon that when speaking about trust and building that trust over time and being consistent. So it's difficult to come up with like a communications campaign. I think it has to really honor that natural communication network. The one I'm most proud of is the Go Slow campaign. I showed a sticker of that because it was created by Be More Power, which is a group of people who are adversely affected by the war on drugs, or their communities are. And it was a very interesting model because they did a 2-day, I think they called it a hackathon. So it was just an intensive 2-day process where people, they had a consultant agency, Mission Media it was called, who really walked through that with everybody and really engaged, and they came up with all these messages, and they created songs, and they created material and design, and then they took a couple days to work through everything that everyone generated to come up with a consensus around the Go Slow campaign. So it was, again, something that's driven by the audience that it's meant to reach, which I think also created investment by Be More Power in actually spreading that message. So they're, that's become such an integrated part of their own Be More Power logo and what they do. So hope that answers the question a bit. Vicki, have you done anything along those lines?
I mean, we haven't done anything, I wouldn't say like consistent messaging. A lot of our material has sayings on them that are like radical love or nothing for us without us is about us. Just sort of like little sayings, but really it's just that connecting. Being out in the street and being face to face has been like our biggest success with getting towards people. For them, we can do that, we can have that campaign, but until you're face to face and I'm saying, what do you need from me? It's not going to really matter.
So Vicki, thank you for the information. I know that you mentioned your OFRT team and reviewing non-fatal cases. How were you able to review these cases? What was the process to begin reviewing these cases? Thank you in advance.
Well, we're starting that. That's a little tricky. We're allowed to. So every county, counties are having the Overdose to Data Action Grant. We're really working on outreach to individuals who have overdosed. We have not had great luck in getting a total review. So we're kind of revamping the whole thing. Just to step back, I get every single overdose report. Eventually, hopefully soon, because we were supposed to do it before COVID, we would have 2 peers that were actual crisis response to the overdoses. But right now we're just responding to reports. So what we're hoping is, we have had luck with that, sort of doing like a two thing question, like a 5-question questionnaire, like what could we have done better? What do you need just to get a good idea. And would you be interested in completing another assessment or being a part of or providing data for? Because they originally had come up with like a 5-page questionnaire, and I was like, that's not going to work. It's just not going to work. So we're really working on that process to get the buy-in and get some more information on the non-fatals, but it's sort of a process. We've had like 1 or 2 so far, but they were individuals who were like in treatment at one of our residential programs.
Okay, thank you so much. It looks like that's all the questions we have. So we want to thank everyone for attending, and we hope to see you in our future webinars, and I hope everyone has a great rest of their day.
Thank you.
Thank you.
Thank you so much.